Hi. Hi, everybody. What's going on? It's your girl, Kelly. I am back with the amazing Dr. Cindy M. Duke today on a Sunday because IG was acting up on Friday. Hey, y'all, I see you coming into the room. What's happening? We are here for you. I am in my home in Pennsylvania. I'm on the East Coast, even though the Eagles are losing right now as we speak, but I am here and nothing is going to stop me. Oh, hold on. I got to plug this thing in. See, the devil is a liar. Wait a minute. I know y'all could hear me, but I need to be able to hear. Okay. The woman of the hour. What's going on, everybody? Tell me where you are joining us from. This is your Warrior Wednesdays on a Friday that turned into a Sunday. It's also mental health, World Mental Health Day. It's something that I learned actually from Dr. Duke this morning. She had an amazing talk on Twitter. You guys have to follow her on every single platform here on IG at Dr. Cindy M. Duke, as well as Twitter. You have to follow her on Clubhouse because she does something called My Dynamic Uterus, and she does talks every weekend, early in the morning, Pacific time, every weekend, educating people with ovaries about their bodies, what's going on, PCOS. We're going to talk about that today. She is just out in these health and wellness streets on every platform. So I really want you to get your pen and paper, send this to some friends. So let's see, we got Atlanta in the building. Hi from Cali, here in Philly. Hey, what's going up? Greetings from Chicago. Still love My Boys. I love that show too. And we text each other every single day. In fact, we were texting each other last night because the guy that played Bobby was hanging out with our ex-showrunner, Irregular. So we are still in that building. What's up, everybody? Mama Stu is in the sunroom. From the sunroom. That's where she's joining in from. Mexico is in the building. Kansas City. Hello from Houston. Hi, thank you for joining. Listen, I need you to share this with a friend. What's up, Dallas, Texas? I see you. Share this with a friend. Share this with a family member. Let them know. We're going to be talking about so many things today. Mental health. We're going to be talking about fertility, infertility, PCOS awareness. We're going to be talking about pregnancy and loss, Infant Loss Awareness Month, which is October. So we got a lot to cover, but before I do that, let me just bring on the woman of the hour because she's a friend. Okay. I can absolutely call her a friend, but she's also, I play favorites. She's my favorite doctor to talk to because she really makes everything so relatable and accessible. Dr. Cindy M. Duke is Yale trained. She's Johns Hopkins trained. She is the head of the Nevada Fertility Institute, y'all. She is also a virologist. I think the only dual like fertility specialist, endocrinologist, and virologist. I know you will correct me if I'm wrong about that, Dr. Duke, as soon as you come on, but she is all of the things. And like I said, she's in these fertility social media streets and wellness streets, making sure you guys have all the information that you need. She really is just all the things. So without any further ado, I'm going to bring her on. Get your questions ready so that you can have them answered by a wonderful friend of mine, this wonderful doctor. Put those questions right here in the question thing. I have some that were DM'd to me. Hey!
Good morning. Oh, it's actually good afternoon.
Good afternoon. Hi, friend. How are you?
I'm good. How are you?
I miss you. And before we even say anything else, I want to say happy belated birthday to you, you beautiful
Thank
queen.
you.
Welcome to your next trip around the sun. I'm so happy that you celebrated. Did you take some time off to celebrate?
Not really. I mean, I was home, but it's okay. It's okay. I think, with the pandemic and everything, usually I travel for my birthday. This year, I just stayed home.
You stayed home. Well, you look fabulous with this blonde hair.
Thank you.
And this makeup going on. Everyone's saying happy belated birthday. You guys, you know what we do here on Warrior
Hi,
Wednesdays?
Dr. Felicia.
Hey, Dr. Felicia. We load up the comment section. So let's put some birthday cakes or some birthday celebrations in the comment section so our girl can see how much she is loved. And we're just praising God for your birthday and this trip around the sun. And as we talk about that, let's start this thing off. I know it's been a while. We've been trying. You've been trying. I've been busy. But girl,
Yes.
we keep our word. We keep our word. We are here. And we were speaking this morning on your Twitter.
Yeah,
about
Twitter Spaces.
Yes, Twitter Spaces, y'all. It was my first time there. It's kind of like a clubhouse. It's like a clubhouse on Twitter. And you were hosting a beautiful talk about mental health. Can you share with us, first of all, the inspiration. There's an awareness day today, or World Mental
Correct.
Health Day. But can you talk
Yes.
to us about the inspiration and share something you said about your homeland and the mental health and the awareness there? Because I think it's really interesting to get into.
Yes. So happy World Mental Health Day, everyone. And so I hosted a space this morning. It was very quick, it was brief, but it was about mental wellness and what does World Mental Health Day mean to you? And that's because, it means different things to different people. And in fact, today, later on Clubhouse at 3 p.m. Pacific, so 6 Eastern, I'll be leading part of their 24-hour partnership with creators on the app, talking about mental health in an unequal world. But today, this morning, I was specifically talking about what the pressures are surrounding mental health when you're raised in a country like Trinidad and Tobago, where part of brand Trinidad and Tobago is that we are one of the happiest places on earth, right? So I grew up constantly hearing that we're happy, we're amongst the happiest people on earth. And the other brand that we have is God is a Trini, right? God is a Trini. That's Trini's colloquial slang for Trinbagonian, a citizen of the country. But really what that means is, in a community, if someone's struggling with mental health, immediately that's seen as that person is broken. Certainly they're seen as if they're embarrassing their family, or that it's a sign that the family hasn't done something right, which of course isn't true. And we all need mental health and mental wellness, but also it meant a limited availability of resources for those who need mental health support, right? And so, in a nation of 1.3 million, we had one mental health hospital that actually didn't have a great connotation. And so if somebody wanted to maybe hurt somebody's feelings or suggest that they're not well, they'll just say, you're going to St. Anne's, because that's the name of the hospital, St. Anne's. And so instead of framing it in a way where people actually recognize that mental health is healthcare, mental health is part of self-care, it's part of community care, it's part of post-colonial care, it's not seen that way. It's seen as the place where you hide away those who you don't want in the community, those who are embarrassing the family. And so, really, that was what I was sharing this morning, and we did expound on that. But I think it's also something that's across many cultures. I think it's the same right here in the United States. We still see it in many other Afro cultures around the world. So on the continent of Africa, Afro-Americans, Afro-Caribbean, we see it. And I'm sure it's the same in certain Asian cultures as well, where the thought of admitting that you might need some mental health support, and notice I'm saying mental health, mental wellness, mental health support, because mental illness has come to take on such a negative connotation, again, as if a human being can't possibly need mental wellness. And of course, during this pandemic, who doesn't, Kelly? Who doesn't?
Ooh, listen, it was, and I think that for me, one of the things I shared on your talk today was that I started therapy 2 years ago, but I will be honest, I really feel like my mom would attest to this. I interviewed a lot of different therapists over the years, because I knew I needed help. I knew that, and we have to start normalizing our mental health as health, because sometimes, because like what you said, we have this stigma, or just pray it out of you, or you're going to be okay. And what I've learned is all of our experiences, the things that make us who we are, our childhood, that whatever was demonstrated to us, on us, childhood trauma, different things like that, all interact, you guys, with who we become, and our triggers, and knowing why we're behaving a certain way. And it gives you such a power to be able to unlock those doors. And they're heavy doors, right, Dr. Duke?
Oh my God, so heavy.
They're heavy doors.
Think about it, right? Every waking moment, this thing has to process something in the world. It has to process what you see, what you hear, what you touch, what you feel, what you smell, right? Just think about that. Yes. It's always on. And then we go to sleep and it's still processing. So
Right.
why wouldn't you need someone to just help you work through the process? And, as I shared this morning, I'm big on delegating, right? If you're a leader, you recognize the need to delegate. Well, I think it's important to delegate to a therapist as well. I
Ooh.
love the idea of having someone that I can say I have a standing monthly meeting with, which I do, and I advocate amongst my family and my patients, because it's nice to show up and just say, hey, let me bounce some things off of you. Let's talk about this in a safe space where there's no judgment and I can share. And I really think just like people have hairstylists, just like they have, nail techs, and I took this from Dr. Sylvia, just like we have all these people who care for us, our outward and inward appearance, we need the same with a therapist, especially if you're going through your fertility journey, your reproductive health journey. When you're working through that intergenerational trauma, listen.
Ooh, she preaching already, y'all. We're 10 minutes in and that's what we were going to say, because there is such a link to
Mm-hmm.
mental healthness and going through the infertility journey,
Oh my
wherever
goodness.
you may be. And I want to definitely get into that with you, especially from a doctor's perspective, doing the physical health of
Mm-hmm.
someone with ovaries or someone with sperm. But it's also Pregnancy and Infant Loss Awareness Month,
Mm-hmm.
October.
Mm-hmm.
And I personally have not been through it. I cannot imagine the experience of that
Mm-hmm. Mm-hmm.
loss and
Mm-hmm.
multiple losses. So
Yeah.
because we're talking about mental health, and because our community in the fertility space really needs to be comforted in this space mentally as well as physically, can you speak from a physician's point of view,
Mm-hmm.
how your patients cope, how they handle, what is something that any tips? I mean, we're not
Yeah.
psychologists, but any tips
Mm-hmm.
that you see that help support those going through something like that?
Absolutely. And there's actually a fertility and mental health psychologist on the line here, Dr. Lori Johnson. So I
Dr.
just want to say, hey, Dr. Lori.
Lori. Hey, Dr.
Yeah. If
Lori.
you guys are not following Dr. Lori Saidi, make sure you're following her. I think, it's really important from the outset to make sure that patients know it's okay to talk about mental health, to talk about stressors as it relates to their fertility journey, and to check in periodically with them as their physician. Because yes, for most patients, they see us as their physical physician, the one who really only focuses on the waist down, which isn't true. In order to treat your waist down issues, I've got to work with you from the head down. I need to
Mm.
understand where your head is at, what your goals are, make sure that we have realistic expectations and timelines, and of course, make sure that you're supported along the way. So I believe in checking in, Kelly. I believe in leaving open communication lines, which is why we have two-way text messaging, for example, at the office, so that someone, particularly when they see the doctor, if I'm wearing my white coat, it's so intimidating sometimes that they may not bring up their psychological issues or their mental health stressors. So I bring it up. I ask.
Mhm.
I'm also what do I call that? A student of what we call the biopsychosocial model. I went to the medical school that introduced that model into medical education, and that is when you're treating the person, you're not just treating their biological, you're treating their psychological, and you're treating their social, right? Your social life, your social issues, your socioeconomic, social justice, all of that feeds into how you biologically manifest so many things, and psychologically how you're able to cope. So I think about all that in part because I was programmed to think that way, which is good, I think, having gone to
Mhm.
that medical school and have that model, which is now expanded to so many other medical school curricula. But it's really important. And I want everyone out there to know that along your fertility journey, your reproductive health journey, different things are going to impact you differently. It's not okay for someone to tell you, well, I didn't feel it that way, so I think you're exaggerating. Oh no. The same goes for pregnancy loss, right? So we use the term pregnancy loss to define what we historically would have called miscarriage, all the way through to pregnancy loss at full term or stillbirth. And
Mhm.
so one of the important things to know about that definition is it means that we recognize and acknowledge grieving. That it's okay to grieve.
Ooh,
Mm-hmm.
that
Mm-hmm.
word,
Mm-hmm.
that's different than, And first of all, I just want to say I'm so glad you brought up Dr. Lori. She was on an episode of Warrior Wednesdays. I'm absolutely I'm obsessed with
Yes,
her.
she's
And so,
awesome.
Dr. Lori, we love you. And you guys, she specializes in mental health for people going through infertility. And she does it from a place of knowing because she has been there. You know,
Exactly.
there's a phrase in my house of like, don't talk to nobody that ain't been through something, because that's how you know that you can relate. But to what you just said in terms of grief, and I think it's really, really important to me, and I'm speaking personally, grief is it's an action almost.
Yes.
It is allowing yourself all of the ways that you need to process to acceptance of a thing that is really, really hard to accept and walk through. And unless you go through the grieving process, because there's getting angry.
Yes. And it's part of the stage of grief.
Part of all of the stages of grief. And so how that deals with infertility, you know, there's something Regina Townsend I know is on here that she always says of getting angry with God, getting angry with, you know, even a physician, getting angry with your spouse or your friend or whatever. Can you speak to that that experience for patients that have had multiple in terms of the grieving, because they're coming back to you, let's try again, that have had multiple losses? What is that like?
And listen, there are people who've had 13, 14, 15 losses. Like, we're talking about people who have, some of them have had one loss and that grief is tremendous, 2 losses, 3 losses, but we also have some for whom it's been as much as 13, 14, 15. Others, they just stopped counting, right? And the grief is the same in that they all hurt. With the grief comes anxiety that it may never work out for them, anxiety that, like you said, right, for some, it's anger at the supreme being, whatever supreme being they believe in, if they do. But the other is feeling like they're being punished, right? Many have actually gone into the mindset that I am being punished for something. And it may even be a history of a termination. And unfortunately, that's one of those things that also has so much stigma and taboo attached to it, that there are people who believe if they're having pregnancy losses now that they're being punished for a prior termination, which is not true. Absolutely not true.
No.
And so we spend time having to help them first unburden themselves from that guilt, unburden themselves from the thought that they're being punished. And so they can come to a journey of self-acceptance, which also includes accepting that the loss happened and coming to terms with the future, including that anxiety about the future. Because even when they are pregnant with a viable pregnancy that's moving along well, it doesn't stop them from grieving the loss, nor does it stop them from anticipating that another loss is coming, because that's part of our psychological protection coping mechanism, right? Is once we've experienced loss, we now expect it. We expect it. We're in a heightened state of it's coming. One of these days, it's going to happen.
Let me tell you something, and let me grab this really quickly. If you guys have not read this book, and Dr. Duke, I don't know if you've read it yet.
Yes.
Gabrielle Union's book, You Got Anything Stronger. She talks specifically in chapter 1 all about her IVF journey and her journey through losses. And I saw you write it down too, Regina, that she actually lost count of how many miscarriages she had and pregnancy losses that she had. I encourage everybody, because, you know, and to the point of punishment, our dear friend who was on with you at one point and asked a question, Sherry Shepard, she was pregnant with twins and lost one of the twins during her pregnancy and thought that she was being punished, as well as those that know my sister Niecy Nash, who also unknowingly lost a twin. She thought she was pregnant with one, and she miscarried and thought, God is punishing me, tie my tubes. And then they found out there was actually still an active pregnancy there. So we take on that mental, y'all. And so it's good to talk about these things so we know that we're not alone. And it's good to be able to refer. And do you refer people to a doctor? I'll tell you a quick story. I went in because I thought I had thyroid problems because I was gaining weight and I wasn't sleeping well. And so I went to go see a specialist, and I got all the panels and everything taken. And I just knew I had a hyperthyroid or an underactive thyroid. I had something. And so when I went for my results, I sat on the couch and I just knew that this man was going to tell me all the things that were wrong with me hormonally. And he said, my dear, your test came back normal, which is good, but I think you might be depressed. And the symptoms of gaining weight, the symptoms of not sleeping, and all of those things. And so he handed me a couple of referrals to therapists. Is that something that you do? And how do patients take it if that is the case?
Yeah, I do that. And I think it's how you come at them with it. So I love the way your physician that you just described did it. So the first is not to dismiss or mute someone's concerns, right? And so I don't say the first thing, oh, you need to see a psychologist, because the truth is we have been programmed and conditioned now to believe that people are quickly going to say, you're not well, you're mentally not well, it's all up here. And so most people are already defensive about that thought, because unfortunately, even in society, we throw that around a lot. We throw it along if we get into an argument with someone. The first thing we do to gaslight them is suggest they're not mentally well. And so as a physician, I don't want to medically gaslight a patient.
Come on.
So it's important to know that.
Y'all write that down. Medically gaslight. I've never heard of that term.
Yeah,
and I
medical
think
gaslighting is a thing. It's a
thing. Ooh, okay, continue.
Yes.
That is something. That is something. Go ahead.
And so the first thing I do is you take a full history like we were taught in medical school, right? You sit and you listen. I sit and I listen. I let the person talk. I take notes. And then I ask myself what physical things could be going on that might be manifesting this, right? Which means I will do all the appropriate testing for you, which is I know there are things that actually can impact mood. That includes your thyroid. It's this butterfly-shaped gland that sits in front of your windpipe right down here.
Oh, right down here. Okay.
But the key to know about the thyroid, it's your body's get up and go hormone. It's literally the hormone that needs to peak in the morning, get you out of bed, get your muscles moving, get your brain out of a fog, out of the sleep fog as well, and get you going. And so the first question I ask myself is, could this be a thyroid problem? What else can contribute to that? How are they sleeping? I know if people aren't sleeping well, they can feel depressed, irritable during the day if you don't get enough restorative sleep. There are many people who go to sleep, but they're not being restored because they're not fully going into the deep stages of sleep, which you need. Maybe you're, as my friend Dr. Romy Mushtaq will say, maybe you have a really busy brain. Maybe you've got a big project coming up. Maybe you're just not sleeping well because you're thinking about the pregnancy losses, the infertility. You're thinking of all the outward criticisms that are coming that people would say aren't criticisms. Like every time somebody meets you, hey, you don't have any children yet? Oh, you have such a big house. Where's the baby? Oh my goodness, I can't believe you're so focusing on your career. When are you going to take time to have kids? All those things. As soon as you lay down, your brain is like, oh, you remember so-and-so said this to us? Remember this? Remember that? Oh, how should we have answered that person? Maybe next time we should do this thing or that thing. And so you may think you went to sleep, but you weren't in deep restorative sleep. So I ask about sleep. I think about what other nutritional things could be impacting them. I happen to know that our gut, our intestines make a lot of serotonin. Serotonin, whenever we talk about that, it's a neurotransmitter. Most people think it's primarily in the brain, but serotonin is also made in the gut. So I want to know, what are you eating? Do you have nutritional problems, etc.? And how do I tie all of that in? And I investigate it. I'll refer you to the necessary people, but also I'm assessing for safety right then and there. Because again, like I said, biopsychosocial model. I want to know that you're safe for yourself and whatever people and entities you're around, and how are you being supported. And so I may even in that first visit suggest that it may be helpful to have some support in terms of objective therapeutic support, right? Because God bless our parents, they're great. But, if they haven't experienced some things, or if they were raised in a certain era, it's just different, right? Like whenever I tell my mom, now she's a huge advocate for telling people you need to go talk to someone. But it took some time for me to tell my mom, who grew up in a very religious society, who herself is very religious, that it's okay to talk to a stranger about things that are going on. My mom, who was a strong single mom, warrior. Her belief is
Right.
you take it to God in prayer, you put it at the foot of the cross, and it is solved. Okay,
Mm,
it is
mm-hmm,
solved. Especially, like I
mm-hmm.
said, we grew up thinking God is a Trinity. So come on now.
Right,
What are you
right,
doing talking to strangers? So it took
right.
a while for me to explain to her, no, this is something we can do in support of, right?
Mm,
And explaining to patients that sending them to talk to someone what my own expectations are for their sessions.
mm.
So to explain, hey, this is who I think would be good for you to meet. This is why I think it would be good to talk to them. So I tell them some of the outcomes that I've seen from people talking to that person, but also explaining that we're not going to medications usually. We're not jumping to pharmacotherapy. Pharmacotherapy is an option if needed, but we're not jumping there. Or for others who stopped their pharmacotherapy because they thought it would get in the way of their fertility. Because that's one of the big myths out
Mm-hmm.
there, Kelly. There are people
Oh,
who stop their antidepressants, they stop their anti-anxiety meds because somebody said, hey, you're trying to get pregnant, you need to stop those. And the majority of the antidepressants and anti-anxiety meds out there, they're safe because most of them are
mm.
SSRIs, which are selective serotonin release uptake inhibitors, which means they help serotonin stay around the nerve endings, the communication paths longer. And in some people, they need that. And so what I tell everyone as they're planning pregnancy, if you have a history of mental health conditions that required medication, it's important to just check in with your team and say, hey, I'm getting ready to start trying. And maybe you're not actively trying, but you're not actively preventing pregnancy. Make sure you talk to them about
Right.
that. And for the most part, your medications are safe. They're not going to cause birth defects. They're not going to cause your miscarriage. They're not going to cause pregnancy loss. And in fact, what we know is a healthy pregnant person, particularly one who's carrying a pregnancy, is a healthier parent postpartum. So if you
Mm.
were someone who required treatment for your depression, et cetera, so that you can function and be a part of your world, don't just stop the medicine because you presumed it's not indicated in pregnancy, or because your family members who've long maybe had some hangups about the thought of you being on medicine took that as an opportunity to say to you, so aren't you going to stop that medicine? Aren't you trying now? You can't be on that medicine. It's not
Mm.
necessarily true.
Very well. First of all, I just got a huge education. I know that you guys did because I didn't know anything about me. We've heard of serotonin, but I've never
Mm-hmm.
known that there was a myth that some of those medications are going to make you infertile or impact your fertility journey. And Dr. Duke just set you guys straight with that right there. So I hope
Mm-hmm.
that you got,
Mm-hmm.
I hope you got those gems. And also just reiterate, because we do look for community, and not everybody can afford a mental health professional.
Mm-hmm.
Not every insurance plan covers mental health,
Mm-hmm.
and I just want everybody watching, and if you know somebody that might need it, just know that there are a lot of people in these spaces of
Mm-hmm.
infertility
Mm-hmm.
that create safe spaces such as Warrior
Mm-hmm.
Wednesdays that we're on
Mm-hmm.
today to be a part of this. Think of it like a virtual support group. I was doing an
Mm-hmm.
interview the other day and I talked about being triggered, and somebody asked me, but you're so vocal about it. And I said, and that's why. That's how I
Yes.
cope with the trigger. Now, that's
Mm-hmm.
me personally. But me personally, I cope with the trigger by becoming vocal. This here, you guys, is my therapy. I want to be
Mm-hmm.
clear. I have not gone through a pregnancy, but as I wait for the thing, and I ask myself, God, did you forget about me? Which I know is a question that a lot of
A
us in this
lot.
community have
Mm-hmm.
asked.
Mm-hmm.
As I wait for that and pray for that and cry for that, when I come here and when I'm vocal about it, this is a space for me to be comforted and supported by you. So it's just, I'm in the comment section as well, y'all. So I just want you to know
Yes.
that there's
Yes.
always a way to activate yourself
Mm-hmm.
that's
Mm-hmm.
if that's something you can do. Not everybody can do that, and you shouldn't judge. But if it's a way, I know Regina Townsend from Broken Brown Egg started Broken Brown Egg while she was going through the
Hi,
journey.
Regina. Yes.
So there's things like that that can help. So I love that. So we just wanted to talk about that a little bit today. And we
Mm-hmm.
also want to talk about PCOS, because we first tried to get on during
In
September, you
September.
guys, which was
Mm-hmm.
PCOS Awareness Month. So our schedules were a little busy. I know I have a question coming in here. I have a question here. You guys write your questions right in the question section there so I can see them and so we can see them. Can we talk a little bit about PCOS, what it is, how it's diagnosed, and what people need to know?
So PCOS stands for polycystic ovary syndrome, and in some parts of the world they actually use PCOD, which is polycystic ovary disease or disorder, but they're one and the same. And so whether you hear PCOS or PCOD, I'm talking about the same thing. And so PCOS is a hormonal condition that really can impact multiple parts of the body, and its primary way of manifesting for most people has to do with their reproductive system, whether it be their period cycles, the frequency of their periods, or it'll manifest in their dermatologic symptoms, whether it be acne or unwanted excess hair growth on different parts of the body. But for a lot of patients, about a third of PCOS patients, they also experience what we call metabolic symptoms. So changes in how their body processes sugar, changes in how their body processes and deposits fats, cholesterol, triglycerides, which can lead to issues with their blood pressure, issues with their heart health, their cardiovascular health, and overall issues with weight and weight gain. And so for a significant number, about 30%, 40% of PCOS patients, they also will have weight problems. But key to all that is recognizing, I'm saying significant numbers of, but not all of them. So what do all of them have? They usually have 2 out of 3 what we call clinical criteria. So to make the diagnosis of PCOS, it's not simply looking at someone and say, oh yes, you have PCOS. We absolutely cannot do that. And unfortunately, for a lot of people out there, particularly women of color, women from multiple ethnic groups who present looking a little bit different many times, they either get pushed into a box where they're diagnosed with PCOS while they didn't fit the 2 out of 3 criteria, or they're left without a diagnosis because people are actually assigning a criterion that doesn't exist at all for the diagnosis. So what are those criteria for diagnosis? There are 3. The first is history of irregular periods. And there's my friend, Dr. Frida, based in Atlanta, triple board certified. Yes.
I love all the doctors in the room. Hi, Dr. Frida. Welcome to Warrior Wednesdays on a Sunday.
Hi, Dr. Frida. Kelly, you do need to meet Dr. Frida. She's phenomenal. And she's a nephrologist, talks about kidney health. And Dr. Sharon Smith is also there.
Hi, Dr.
OB-GYN colleague.
I love it. If y'all get us done, you can request to come in at the end if your hair's done. You know, it's up to you. We could get all the doctors on here at once. I love it. Welcome.
They're amazing.
Welcome.
So the 3 criteria is, first is history of irregular periods. And irregular periods means for some people, their periods come really frequently. For others, they're very spaced out, or they don't happen at all unless a doctor gives them medication. So irregular periods is one of the criteria that you might need to meet. So not everyone with PCOS, however, is going to have irregular periods. It's important to know that. But 1 out of the 3 is that. The second is history of what we call androgen excess. And we term androgen is the medical term for testosterone and its byproducts. So clinically, that would mean either history of acne problems on the face, chest, back, lower abdomen, or upper inner thigh. Oh yes, people can have acne. We call it backne, right? Acne on the back. Acne on their chest.
I have that, y'all. I have that. I'm not ashamed to say it's not PCOS related. It's something else, but I do have it. So and that's a symptom of it, right?
That's one of the symptoms.
That's one of them.
And it's important to say one of, because when we're talking about PCOS, emphasis is on the S, the syndrome, which is a constellation of symptoms. And so evidence of acne or unwanted excess hair growth. So hair growth can be on the face, the chest, the back, the lower abdomen, upper inner thigh. For a lot of persons, they end up shaving that, waxing it, lasering it. And so we actually use a graphic, a pictorial known as the Ferriman-Galway scale to help people objectively define what their hair growth pattern looks like if they weren't actively removing it. And if you have a score higher than 11 on that test, that's an objective way of defining what we call excess unwanted hair growth, or hirsutism, which is a medical word. So that's 2 out of the 3. Or on blood work, we see elevated testosterone. Now, the elevated testosterone test is an interesting one because most people think, oh, my levels have to be in the levels of what a guy, somebody born with testicles, has. That's not the case. We're really looking for testosterone either total testosterone in your blood being elevated for someone born with ovaries, or on blood tests, we see that you're free, the circulating active part of your testosterone panel is actually high enough that it is stimulating that what we call terminal hair growth. That's where the hair that's growing on the face, chest, back, lower abdomen, inner thigh gets darker, it's sharper, coarser. That's called terminal hair growth. And testosterone is what leads to that. And so we look for that. And then third would be on ultrasound, looking for evidence of polycystic ovaries or polycystic appearing ovaries on ultrasound. And this is part of the issue with PCOS, is the C is actually what we call a misnomer, because we're not really looking for big cysts, right? The truth is most people with ovaries will make cysts at some point in their life. And one of the big myths out there that I see with people is the moment they hear the word, oh, you have a cyst, they assume that means, oh, they're telling me I have PCOS.
Mm-hmm.
That is not true. They're not one and the same at all. In fact, PCOS is really PFOS, polyfollicular ovary syndrome. Because that's what we're looking for on the ultrasound. We're looking for egg houses or follicles, and we're looking for lots of them. So we're not looking for big cysts. We're looking for tiny egg houses that are there in large numbers. And so typically we're looking to see at least 12 or more in the ovary, or the ovary needs to measure greater than 10 cubic centimeters with the absence of big cysts, right? And it's important for people to know that, because I can't tell you how many people have come into my office and they say, well, I think I have PCOS. And I say, why? Well, my doctor told me I have cysts. No, and the majority of us make cysts. In fact, every month, those who have regular ovulatory periods, we make a special cyst every month known as a follicle that releases an egg, and then that follicle that released the egg turns into what's known as a corpus luteum cyst, awaiting to see if you get pregnant. So it's important to clarify that. I know it sounds like a nuance, but it's a big deal. Mm-hmm. But those are the three things. Do you notice what's missing? At no point in those three things did I mention weight. At no point in those three things did I mention cholesterol or diabetes or prediabetes. Why is that important? That's important because I can't tell you, Calais, how many lean PCOS people who were told you can't have PCOS because you're not overweight. Mm-hmm. The truth is the majority of people with PCOS don't have an active weight issue, right? Some of them do. Some of them do.
Mm-hmm. But the majority, because Nicole Sublette, for those who haven't seen, go to the IGTV here. Nicole Sublette was what you're describing, a very active, very fit woman. She had irregular periods all through college and has PCOS. And so I love that you brought that up, because these are the misconceptions. These are the misconceptions.
Big one. It's a big one. You know, we saw Keke Palmer come out and share about the fact that she struggled with acne and period issues for years. And no one thought to mention that to her because they kept telling her, it's not possible, you're skinny. So one of the big things we do with the advocacy around PCOS is not just educating potential patients and families about PCOS, but we're actively educating our clinicians, right? Because we're part of the problem in many ways, because we're dismissing those who actually have it. And then there are those who have weight issues due to other things, who, because they have a weight issue, they're immediately told, you have PCOS. That's what you have, because you have, but weight is not part of the diagnosis. And so, yes, you could be overweight and have PCOS, but you can also be lean and have PCOS. So if someone's telling you you have it or you don't have it, the first question you should be asking either way is, can you tell me how you made that clinical decision? Because if they're not using the clinical criteria, the three that I just described, which are known as Rotterdam criteria, named after the city of Rotterdam in the Netherlands, where they first identified and defined the syndrome, then they're not doing justice by you. Okay.
I need to pause you really quick. Y'all, I gotta snap it up, because what you're saying, and I want you to continue, you are giving people the tools to advocate for themselves within their appointments with different doctors, to say what brought you to that clinical decision. I want you guys to write this down. I want you to learn to advocate for yourself, to know the words, to use your words, to ask the questions, or to bring a friend with you, because this is invaluable information. So I love that. Regina wrote it down. Can you tell me how you made that clinical decision? Okay, keep going.
And here's the reason why. So maybe they might quickly say, really? Well, I'm the doctor, or I'm the nurse practitioner, I'm your clinician. And you follow up by saying, well, I understand that PCOS can look different in different people. I'm trying to understand my PCOS, right? It's important to know your PCOS, because here's the thing, right? Someone may be diagnosed with PCOS because they have a history of irregular periods and polycystic appearing ovaries on ultrasound. Great. But another person may be diagnosed whose periods are completely normal, but they have elevated androgens and polycystic appearing ovaries. But here's the other kicker. There'll be another person diagnosed who has elevated androgens, so the hair growth issues or the acne issues and irregular periods, but normal looking ultrasound. Right? And so you need to know, what does your PCOS look like? And so that's the way to couch that, what helped you make my clinical decision. It's not that you don't trust them as a clinician, it's so that you can be empowered to know what you need to work on and what your PCOS looks like at the time. And why do I say at the time? PCOS also evolves as we age. It evolves as we age. So what your PCOS may look like in terms of clinical symptoms in your 20s can be very different from what it looks like in your 30s and 40s. You know, again, including in PCOS, we're born with all the eggs we're going to have. As your egg numbers decline, you might actually get to a point where you go from irregular periods to regular periods.
Oh, you did? Can you guys hear me?
I can see you now and hear you.
Oh, okay, sorry. Okay. I didn't go nowhere. I'm loving this.
Yes,
okay.
Awesome. You know, if someone's periods were irregular, but now they've become regular, that doesn't mean you don't have a history of PCOS. It's evolving, and we still need to make sure. But the biggest reason why we need to diagnose PCOS has nothing to do with fertility, actually. And I say that because we end up ostracizing so many patients out there simply because we only think of PCOS in the context of reproduction. PCOS can impact so many different parts of our system that whether you're a transgender male, whether you're someone born with ovaries, identifies as cisgender female, but maybe doesn't really want to have children, whether or not you're someone who's had a hysterectomy, if your ovaries remain, and even when the ovaries have been removed, the cascade of events for your PCOS could have already been put in place that leads to high blood sugar or difficulty processing sugar, which is prediabetes and diabetes. And in this country, we have 88 million people who are living with diabetes. Some of them are people with a history of PCOS, but no one caught it. Some of them are people who knew they had PCOS, but it wasn't well managed. And so, you know, either the clinicians didn't manage it well, or the person who had PCOS, it wasn't explained to them that it could lead to PCOS and what sort of personal responsibility they need to take to reverse the course. Because here's the thing about PCOS. We don't have a cure, but it is reversible. You can live a life with PCOS under really good control. It's also important to know that what it takes to control your PCOS in your 20s may be different from what's needed in your 30s, certainly what's needed in your 40s, and what's needed in your 50s and 60s. Because yes, even if you've gone into menopause, PCOS can still be taking a toll on your body in terms of your risk for stroke, risk for heart attack. We know that people with a history of PCOS are up to 3 times more likely to have a cardiovascular event even in their 50s, 60s, 70s. So it's important that it be managed. It's important that you still have those routine checkups, whether or not you're trying to conceive, whether or not you still have periods, whether or not you still have a uterus. It's important to know that. Why do I talk about reversible? I think for a lot of people, when they get the diagnosis of PCOS, Kelly, they're stunned, right? And so naturally they go online seeking information, and they end up in these horrible rabbit holes that are, a lot of them is multi-level marketing this supplement, that supplement, this thing, that thing, which with no concern really about your type of PCOS. So this is why it's important for you to know what your PCOS looks like. The second is there are lots of really poor promises being made, and a lot of these online marketing things are geared toward people's anxiety about PCOS and the fear that people out there are doing. And someone says it's always MLM. Now, no shade to MLM. There are a lot of great MLM companies out there, but there's definitely active marketing geared at selling false hope to PCOS patients, geared at stoking their fears and scaring them into spending money on things they probably don't need or things that aren't really validated for their situation. And so the big thing I tell everyone, and we do a room every week on Clubhouse called, in my club, My Dynamic Uterus, it's called Let's Talk PCOS Weekly, because clearly
I'm a frequent flyer there.
yes, you
I'm
are.
a frequent
Yes,
flyer,
you
y'all.
are.
Yes,
And we do that room because, of course, it's obvious we can't complete a PCOS talk in 20 minutes, 30 minutes. And so it's an ongoing weekly conversation that we've been doing since December 2020, and we do it every week. Dr. Sharon is one of the physicians who joins us when she can. She also joins me on the Saturday period rooms. And Dr. Frida, too, comes to the Saturday period rooms. But I think what's important for people to understand is PCOS means that it's not just one doctor's appointment. In fact, one of the things that I know, and we know this from the psychology of clinical science and the psychology of decision making and delivering news, which PCOS, immediately people hear it, especially if they were looking it up before, and they start thinking the worst, because only the worst stories tend to be online. And of course, one of the biggest other myths for PCOS in someone who perhaps wants to have children is there are a host of people out there who tell folks with PCOS you can't have children, which is not true.
Right.
PCOS does not equal sterility. It does not equal sterility. And we have to keep saying it because there are even physicians out there and clinicians who have told people that. There's a whole TV show that features a lot of what I would tell you are PCOS patients. It was called I Can't Believe I'm Pregnant, because it's literally a bunch of folks who don't have regular periods, who were told they can't get pregnant. And of course, unfortunately, it turned it into a TV show where a lot of people were making fun of those folks. But medically, I could see why that happens, because you always see many of them would say, oh, the doctor told me I could never get pregnant. How did this happen? And the truth is, you can get pregnant with PCOS. The majority of people with PCOS actually get pregnant without any assistance from people like myself. That's the other thing that is out there that is a fallacy. Now, some of them end up needing help, and it can be somewhere between 15 to 30% of them need assistance if they're not ovulating regularly, or maybe they have other underlying issues going on that also need to be addressed to get them pregnant. But I want people to know, first and foremost, if you have PCOS, even if your periods aren't regular, if pregnancy is not something you're hoping for right now, you need to take contraceptive measures, okay? Don't go out there thinking, oh, I have PCOS, I can't get pregnant, I could do whatever I want. Don't do that.
Tell it, Dr. Drew, don't do that.
You still need contraceptive measures if you're having relations with someone who's making sperm. It's important to know that. And similarly, if you have PCOS and maybe your periods aren't regular, I see Regina says here, if you have PCOS, you may not have periods. So add that to having been told that you can never get pregnant. And ta-da, I didn't know I was pregnant episode. Absolutely. Absolutely. And so it's really important to make sure that you know your body, make sure that you know the facts. And so really, I'm big on debunking PCOS myths. I've even created a number of different social media things and blogs, and I contribute a lot to media outreach because, one, I want the truth out there, but I also want people hearing the truth across different ethnic groups, because in so many parts of the world, while we think PCOS, about 10% of people with ovaries have PCOS, we do think in certain ethnic groups, the numbers could be as high as 20%. And it's
what are
not
those
being
ethnic
diagnosed.
groups?
So those of African descent, those of Southeast Asian descent, for sure, we're seeing those. But we're also seeing, in general, PCOS is taking too long to be diagnosed, much like endometriosis, much like fibroids. And we really think part of it is, the motivation. Is there a motivation to make sure patients understand? But also amongst patients, is there an understanding of what PCOS means? And again, you know, if you go online and you read the worst about PCOS, you don't really want to hear that diagnosis. So
Right.
even if someone tells you, you go out in denial, you go out seeking the cure. You're seeking the supplement here, the supplement there, you're seeking this, that. And many of those things are amazing adjuncts, but the first thing is recognizing if you really have it and knowing what type of PCOS you have so you can work on it. For example, if someone has PCOS and weight is part of their PCOS picture, meaning as a result of what's going on in their body, they now have weight issues, then we need to work with them on losing that weight because it can really help even their ovulation if they're trying to conceive. And so I know there are people out there who are like, I think I have PCOS, but I don't want to go on no fertility medicines. You may not need to go on fertility medicines if you have PCOS and are trying to conceive, but we need to evaluate you. Knowledge is power. Be empowered. Get the information.
Yes, what we know for sure is ignorance is not bliss when it comes to your health, y'all. Mental health, your physical health. And so getting to know that, and you taught me so much in this because knowing what your PCOS picture looks like and how it behaves so that you can then develop a lifestyle to help your body regulate. So you guys, these are the things that you need to know. And before we move on to questions, if you guys have a question, I see them coming in the comments. I have a couple that were DM'd to me that I just need to ask. Please put them in the question area here before we wrap up so that we can get them answered. And now I lost my train of thought. What was it?
Well, I have something to share.
Yes,
which is what we do see in PCOS patients. It can lead to a lot of mental health strain, right? Some of it has to do with body image issues, right? Imagine growing up with here, there, everywhere, the teasing that happens in school, the way people make fun of the hair growth that you aren't actively growing hair, but it's happening, right? But people tease you, even within families, I do remember growing up and seeing people tease young women who had a lot of hair on the face, etc. And make no mistake, for some people with that hirsutism, they're literally having to shave daily. Some of them by 5 p.m. they shaved in the morning and they've got a 5 o'clock shadow for real, right? Imagine the self-esteem and body image issues that comes from that. For the ones who maybe struggle with weight as a result of part of their PCOS picture, imagine the body image issues that come from that, the self-hate that can develop.
Yes.
And so it's really important that we identify these things early, particularly in our young patients as well, so that we can, one, help them develop that positive body image, help them take ownership of their identity, who they are, take ownership of the genetics in the family, but also to help the extended family, right? I cannot tell you how many experiences I've had of a patient with PCOS, and we make recommendations about nutrition, diet, exercise, but she's living at home. She's a teenager, and her family, they're still eating all the other things that we told her to maybe try to start limiting, avoiding. I've literally had parents who tried to call up the clinic and say, hey, tell Dr. Duke, she's not following what you told her to. And then we schedule an appointment, because part of the appointment is I want to talk to the parents, because I want to know, what are you doing to help the circumstance, right? So for example, if our recommendation is that she start cutting out refined food, sugars in her food, etc., but you guys set up the table for, let's say, breakfast, right? I know many people don't have breakfast together anymore, but some people do. Or there are other kids in the home. If everybody else's breakfast is all the great cereal and the sugary cereal and this and that, but
how are we helping her?
How are you helping her? Giving her a healthy plate? No. In fact, you're ostracizing her within her own home. You're ostracizing them within their own circle that should be safe. And so it should be a family-based change, especially because PCOS usually runs in families, right? But it may just look different amongst different members of the family.
And I'll be honest with you, Dr. Duke, I really didn't even know what PCOS was until I was a part of this community. And I wanted to ask you quickly, what is the average age that someone is diagnosed with PCOS? Because I find the fact that there's so many mothers or aunties or older cousins out there that don't actually know this
Mm-hmm.
information.
Mm-hmm.
They themselves don't know whether or not this is something
Correct.
that they have. And so,
Mm-hmm.
what's the average age so that we can start to really spread the word?
Mm-hmm.
Because it does
Mm-hmm.
affect children and their mental health and how they see themselves. And it's hard
Absolutely.
enough living in the
Absolutely.
world with,
Yeah.
yeah. What's the
Yeah,
average
and
age for that?
so the average age depends on when you started your period. So we do not diagnose
Mm.
PCOS in the first 2 years after you started having periods, which is called menarche. And that's because it takes 2 years for the axis, meaning the hypothalamus, the pituitary, the hormone centers in the brain, to really
Ah.
activate the full conversation with the ovaries and your adrenal glands. It takes 2 years after you
two
start
years
bleeding.
after you
Mhm.
start your period. Okay,
Correct.
for
And
everything to talk.
to finish talking and really figure out its maturity in terms of the signaling. And so
Okay.
it depends on how old she was when she started having her period. So, for example, if she started at 9, and yes, right, the average age for first period in Afro American and Hispanic girls, for example, in the US is age 8.
Mm-hmm.
So I know it's hard to hear that an 8-year-old is having a
A
period. It's
period.
hard to imagine an 8-year-old needing to take breaks and go to the bathroom to change her pad at 8 years
Oh, at
old.
8, a baby.
Yeah, but that is the average age. And so what that means is really we wait 2 years. So the earliest could be 10, right? It could be
Mm-hmm.
10 years old. It could be 12, 13, 14. But the key is those 2 years from
Okay.
menarche. We give them 2 years from menarche before we call it PCOS after establishing the criteria. So it's not just, oh, she had a period, or they're irregular, or she didn't have a period for months, but now it's really heavy. We do have to give the system time to finish the maturity of
Mm.
that, what we call HPOA axis. But once we diagnose it, then we have to make sure we're doing right by them, which is diagnosing it, looking for other things, like I said, so signs of metabolic dysfunction, diabetes, pre-diabetes. Yes, we diagnose type 2 diabetes in kids as young as 10, 11,
Mm-hmm.
12 sometimes. It's not always type 1 diabetes. You
Mm-hmm.
know, we used to call type 1 diabetes juvenile diabetes, which meant if you were under a certain age and we found you to be diabetic, we just lumped you in there. We now know it's not that. There are different processes at play that can lead to it, and we can see that. We can also see weight issues in children. One of the things I still feel bad about is when I moved to the US, I used to watch Ricky Lake and Jerry
Oh, yes.
Springer and Sally Jeffsey Raphael. That was part of my learning American culture when we moved to the US. And I still remember the shows where they'll bring in the kid who's really overweight, and you'd see them shaming the little child and shaming the parent, and the parent's like, I don't know what to do. And you'll see members from the audience stand up and go at the parents, and it's your fault, it's your
Mm.
fault. And the truth is, it's so complex, right? And a child can have hormonal issues going on, whether it be PCOS, whether it be something else genetic that's informing their cravings and the issues with food and body image and so forth. And I now think back to those moments, and I'm like, oh man, I wish there was a doctor like myself who was on that TV show that didn't shame the kid
Yeah.
and the parent, and explain to the audience, hey, this is a moment for us to learn what this could be and how we help as a society, right? And so it's those things, but body image issues are a major, major concern. And we actually end up with a lot of PCOS teenagers, Kelly, who develop eating disorders, who develop body image issues that lead to eating disorders, those who end up working out and actually develop anorexia by exercise. This is
Mm-hmm.
something
Mm-hmm.
that many people aren't aware of. Many
Mm-hmm.
people think anorexia is simply starving yourselves, but there are other people who eat, but then they'd work out so much that they burn so many calories that they're still at a calorie deficit because they're working out so much. And that over time also takes a toll on their muscles, their bone health, etc., because they're still malnourished. And
Mm-hmm.
so we have to be really careful and specific when we
Mm.
look at these young people in particular. It's why I was one person when I heard that Instagram was rolling out an under 13 app. I was like, no, because we
Mm-hmm.
happen to know that social media, it's not only harming those who are older, who hopefully usually have more critical appraisal skills, but it really wears down on a young person who's
Yes.
seeing those things.
Yes. Well, I mean, you know, what's so beautifully interesting about this is that it's all connected, you guys. You know, talking about PCOS, talking about mental health, body shaming, being young, all of these conditions that we struggle with, that we're challenged by. The one thing can feed into another thing, and we don't even know how to unpack that yet. But you know, Dr. Duke, I wish you were around when those television shows were doing that. And some of them really still are. But I love the fact that you mentioned it now, because even just one person hearing that from you is going to be changed in their own perspective and how they view the children in their family or around them. So it is all connected. Okay, real quickly, I have a question for you. Someone is getting their third procedure for fibroids, and the procedure is ACESSA.
Yes,
ACESSA. ACESSA is how I have it spelled here. Can you please just let us know what that is, how it works, and just a little background about ACESSA for fibroids?
So ACESSA is a radio frequency ablative procedure, and I'll explain what that is, but it's literally RFA. So if you start reading and you see the words radio frequency ablation, or you're reading a textbook and it says one way to treat fibroids is radio frequency ablation, RFA. In the US, the company that makes the commercially available radio frequency ablation is known as ACESSA, and it was recently acquired by a company called Hologic, Hologic. Now, ACESSA is interesting. It still involves making a cut in your belly. So we actually go in laparoscopically, but it's a wand. What's interesting is,
sorry, that's my phone.
Okay.
Mama Stu will get it, or it'll ring out. Sorry, y'all.
That's okay. So it really means, one, going in with a camera, laparoscopy, and identifying the location of the fibroids. For the most part, as OB-GYNs and specialists who treat fibroids, we would also usually order an MRI to map the location of your fibroids. But the ACESSA itself actively has an ultrasound attached to the probe that the device has. And really that's what we're going to be talking about, is the use of ultrasound waves to deliver energy that would ultimately lead to the fibroids melting or shrinking on themselves. And that's the point. The key things to know is that at the moment, ACESSA is still relatively new, although it's about 10 years since we've been talking about the technology, writing about the technology. I remember writing a textbook chapter for a book on fibroids back in 2011 and talking about radio frequency ablation at the time, because it wasn't commercialized or branded yet. Now it is. And so it works to help shrink the volume of the fibroid. And so it's a minimally invasive surgical method that's available for shrinking fibroids. In terms of people who are actively trying to get pregnant, we don't have enough data that says it's the best way to shrink fibroids to still help you get pregnant afterward, but it's not absolutely contraindicated. And in fact, it's even recommended now by the American College of OB-GYN as one of the treatment options. So what I tell people is there's no one I can look at on the live and just say, you're a good candidate for ACESSA. But I would say ACESSA is an option. Go in and talk to your OB-GYN. If your OB-GYN doesn't know about it, don't feel bad. Many of them aren't doing it yet. And they may not know it as ACESSA, like I said, because that's a brand. That's a company name. It's radio frequency ablation. So you may find that you need to travel to find the doctors who do it, but you want to make sure it's the right option for you. There are many options for fibroids, right? So there's that, ACESSA, which is radio frequency ablation. We have uterine artery fibroid embolization, so UFE. We have myomectomy, which is going in with an incision and taking out the fibroids. That could either be an open myomectomy, known as a laparotomy myomectomy, or you may do it laparoscopically, and they use a robot, which is robotic assisted laparoscopic myomectomy. And then there's hysteroscopic myomectomy, which is they're going in via the vagina and taking care of the fibroid that's sitting in the uterine cavity. So it's really important not to just jump on the newest thing you see advertised, because I know there's a lot of heavy marketing going on for Acessa right now. And it makes sense because the company needs people to know about it. And in specific patient groups, it works amazingly well. It's a great option without hysterectomy. So all of those options I just listed are options outside of hysterectomy, but not all of those options have been fully proven to preserve fertility. So it's important when you go in to talk about these things that you not just talk about the fact that you want to treat your fibroids, but if part of the reason you're seeking out these options is that you want to preserve your ability to carry a pregnancy in the future, you need to make sure you say that. And I know Dr. Sharon would agree with me. As an OB-GYN, I would think the OB-GYN would ask you that question.
But they
I
don't.
would think, but they don't always. And
they don't always.
Especially in patients of color. There are these unfortunate systemic biases that lead to them assuming, you know, oh, you're a certain age, you must already have kids and you don't want any more. These are assumptions and biases that lead to, it's an implicit bias in this case, that leads to them not asking you the right questions. And so again, this is why I advocate and I tell the potential patient, you need to bring up that you're seeking something that will keep you with your future fertility options intact. If you're done and you know you're done, it's a great option. So is fibroid embolization as well, but not if you're actively thinking that you want to be able to carry a baby in the future.
Or if you don't know yet if you want to carry a baby in the future, you need to say that, because you could change your mind at some point. So you need to say that. Dr. Sharon says, I agree. I ask, what are your plans for childbearing? I so love that. Yes. I know that a lot of doctors do, but I've talked to a lot of women that it's not happened. And it didn't come up, and that was unfortunate, and we want to make sure. Okay, let's see here. Someone is asking, do you have long-term hair loss on the head and acne? I think that is in regards to the PCOS.
So we can see a paradoxical hair growth picture in some PCOS patients, which is they have excess unwanted hair growth on the face, chest, back, lower abdomen, upper thighs, but we see a paradoxical loss of hair in what we actually call now female pattern balding, which is actually something different, because in the old days, and by old days, I mean as recently as 10 years ago, we told people it was male pattern balding. But really what we see in some patients is they lose hair temporally and then central balding right up top. So it's not male pattern where it extends all the way back necessarily, but up here. And so in a patient like that, there are a number of options that we can use to treat that. I'm a huge proponent for getting my dermatologist involved early in my patients who have that second criterion, which is the evidence of androgen excess. So if they're showing acne issues, if they're showing hair growth issues, you know, there are things I can do to treat in the immediate short term, which include oral contraceptive pills. And I know there's a huge movement, birth control pills are bad, they're bad, they're bad. But actually there are multiple different types of pills out there. And this is the other thing I advocate a lot weekly in our PCOS room, is if someone is suggesting oral contraception to you, the first question is to ask, what is the rationale for you? Okay. And so, because, you know, like many people think it's just doctors and clinicians, they just reflexively say go on birth control. But the truth is there are multiple reasons for why we may recommend a hormonal pill that happens to fall under the category of birth control. But we don't use those pills only for preventing pregnancy or only for birth control. We use them for a variety of other things. In a PCOS patient, we especially use it in two categories. So one would be the person who doesn't have regular periods. A person who doesn't have regular periods, meaning their periods are spaced out or they just don't come on their own, that person is at increased risk of the lining of their womb thickening and transforming into a cancer. Right, precancer or cancer.
Can you say that again? And the reason I say that is because a lot of times we normalize an irregular period. Correct. And a lot of times we get busy, or we even see it in children, and we say, you know, I just don't have regular periods. Can you please just say that?
But it's not normal. So if you have PCOS and you have irregular periods, one of the things we know is your ovaries are actively making estrogen. You're just not ovulating, and therefore you're not making progesterone, which is the second hormone that should be released during a menstrual cycle to actually stabilize the lining. It's usually to wait to see if a baby's going to come. But if a baby doesn't come, then your progesterone levels drop, you have a period, and it starts again. In someone who's not having regular periods, all that's happening is your lining is seeing estrogen. Estrogen is an amazing proliferative hormone. It leads to the linings thickening up, and it keeps thickening. Eventually, if it gets too thick, it'll shed. And that's when people have the heavy breakthrough bleeding, maybe once a year or once every few months. But the problem is that constant estrogen can also lead to transformation of the cells in the lining of your womb so that they become precancerous, or what we call endometrial hyperplasia, which is overgrowth and transformation. And that transformation can continue such that it becomes a cancer or an endometrial cancer. So PCOS is a risk factor for endometrial cancer in those who have history of irregular periods. And it's important to know that.
Wow.
I've had patients in their 20s diagnosed with hyperplasia and early stage endometrial cancer. Now, nowadays, if we can catch it early, whether it be hyperplasia or early stage cancer, we can actually reverse it with appropriate hormonal therapy and allow someone to get to the point where they can carry their own children before they need a hysterectomy. Now, I say before because once you've been diagnosed with an endometrial cancer, the cure is removing the uterus. Mm-hmm. The question about removing the uterus is whether we can reverse it long enough to get you pregnant, help you have your children, and then we remove the uterus, or and this is a patient decision. Some patients would say no, especially if they have genetic risk factors, because there are genetics behind endometrial cancer as well. Let's say they have something that we call Lynch Syndrome, which is endometrial cancer, colon cancer that runs in families. Mm-hmm. They may say, the risk is too much for me. Take out my uterus, let's freeze my eggs or create embryos and have someone else carry for me. Mm-hmm. That can happen too. But it's important that we talk about that. So how do we prevent that in PCOS, to jump ahead? Birth control, contraception. And it may be that somebody goes on a pill every day, or it may be that I schedule a bleed for them once every month or once every 60 days to keep that lining shedding so that it doesn't transform over time. So that's important for people to know. So that's one way we use pills, and we have different formulations or combination of hormones that we use. For some people, it might just be progesterone once every 60 days. That's it. I give you Provera for 5 to 10 days and you bleed out. Now, for other people, though, they have the testosterone problems. They've got the acne, they've got the hair growth issues. Well, one of the things we know is if we can increase the numbers of the magnets for testosterone that's circulating in somebody's blood, we can effectively decrease the amount of testosterone that goes to the hair follicle and the amount of testosterone that goes to the base of the pores, those sebaceous glands that make all the oils that clog your pores and cause acne. So we use pills, certain types of pills, to help with that. So the key again, right, to help people become advocates is go with an open mind, but also ask your clinician, can you tell me why I'm on this? Right? Because it's important for you to know. That way you can counter when friends are like, oh, did they just put you on pills? And you can say, well, this is why they put me on
why.
this pill.
And you need to know why. You need to understand the why. I want to get to one question because, and then just a couple more, Dr. Duke, because she has another event today, y'all. She's busy in these streets. Because Casey, who asked the question, also had a first part of it that I missed. What androgen tests do you need? Because I get dismissed about the hair loss and the acne. My thyroid tests are always normal. Period is normal. Do I go to an OBGYN or dermatologist or endocrinologist? What androgen test does she need is what she's asking.
The androgen test, and first of all, I didn't share this earlier, but PCOS is a diagnosis of exclusion.
Yes.
So actually, PCOS is a diagnosis we land on after we've ruled out all the other things. And so again, that's why I started off saying, you know, it's important that people ask you the full history, the full scope, because there are people who have things that look like PCOS, but it's not because of PCOS. It's because of maybe something going on in their adrenal glands. Maybe they were born with a deficiency in a certain enzyme that helps them make certain types of testosterone byproducts in the adrenals. What are the adrenals? They're these small glands, hormonal glands that sit above your kidneys, right? And they're critically important. The adrenals are what make adrenaline or norepinephrine, your flight or fight hormone. Now
Mm-hmm.
recognize, right, this one, thyroid, is your get up and go.
Okay.
Without thyroid, your muscles don't move well. People with extremely low thyroid function, they can't even walk well. They're so slow, it's going to take them hours to make it just from their front door to another room in their house. And I've seen this in practice. I had a patient when I was a resident at Johns Hopkins, and she had such a severely underactive thyroid that at first they thought she wasn't taking her medicines, which unfortunately is what happens, particularly with patients of color. The assumption is if the numbers look bad, many people start out by thinking you're just not following the rules. And while some people don't, that usually, unfortunately, is what people jump to first. And so after prescribing her the highest possible dose for thyroid medicine, and she wasn't responding, she actually was then told to show up to the hospital every morning at 5:30 a.m. so we can watch her take her medicine, right? Because the decision was made that she's probably not taking her meds. And so we would get a call when the security officer saw her show up at the front door. And it would take her another 45 to 50 minutes to make it from the front door of the hospital to what would be about 20 feet to get to the elevator so she could take the elevator up to the floor where labor and delivery was.
Oh.
And that's because of how slow you end up
Oh.
becoming if your thyroid just isn't working. You also gain weight. It's called, the medical term is myxedema, myxedema, because fluids just build up all over your body. You swell up, right? And also we see different things in terms of mood. People get very depressed. Some people may even actually start having suicidal ideation, the get up and go. And I point that out because it's different from the flight or fight, which is adrenaline, which is something scares you and you're like, ooh, and your heart starts going faster because you got to move. But that's different from thyroid. And I need people to know that because many people confuse the two. And they're like, well, that's impossible that thyroid is important for your movement. It's critically important for your movement. In fact, if your thyroid is overactive, one of the first things that happen is the muscles around your eyes change and your eyes start bulging out.
Yes. That I know.
Yeah,
Yes.
because it works on your muscles there. Your heart starts beating really fast and doing weird things if your thyroid is overactive. And you feel anxious. So instead of feeling depressed, you now feel anxious and you feel like the world is going to end. You start getting panic attacks a lot. You start feeling this sense of doom. Like something bad is going to happen. That's an overactive thyroid. But if you can imagine that's overactivity, then the converse, the complete opposite is what happens with underactivity. But it's important that we know these things, right? Because so many people aren't told this kind of stuff, and instead they're told it's PCOS. So she shows up, she's got a weight issue, she's telling the doctor that she's swollen and things don't fit right, and she's sad all the time. And somebody says, you just eat too much, stop eating, stop eating. Or you have PCOS, go work out. And that's not her issue. Her issue is this, the thyroid, or it's something going on in her adrenals, or it's something going on with another hormone. And so it's important that they look at the whole person, head to toe. And the same thing happens for things with like hair loss, etc. Yes, we can see PCOS patients with hair loss, but if they're telling you you don't meet criteria for PCOS, it's not usually just based on labs. It's based on those 3 clinical criteria, Rotterdam criteria. But if you don't meet Rotterdam criteria, it doesn't mean that you don't have an issue going on. It means now we look at other things. We look at your adrenal glands. We look at the ovaries to make sure you're not making a tumor that's churning out high levels of testosterone. Or we look at, like I said, that magnet for testosterone in your blood, which is known as sex hormone binding globulin. If your sex hormone binding globulin levels are low, then you're actually going to have a lot more active free or bioavailable testosterone acting at the hair follicle or the sebaceous gland. So yeah, your total testosterone levels may look fine, but what we care about is the fraction that actually ends up at the follicle. So the test, that was a long way to get to what test, is you need a testosterone panel. So the testosterone panel should include total testosterone, sex hormone binding globulin, SHBG, and free testosterone, which you can actually calculate if they give you your total and your sex hormone binding globulin levels. But you may really just need a second opinion with someone who knows that stuff.
Drop that mic. Let's go to the next question. I hope your question was answered there in case you need testosterone or you might need a second opinion.
Mm-hmm.
Okay.
Hi
Oh
guys, I
boy.
see Dr. Lloyd Brown just joined. Lloyd Brown and I went to medical school together. He's an amazing transplant surgeon there in New Jersey. Hi, Dr.
Hi,
Brown.
Dr. Brown. Thank you for joining us today. All right.
Mm-hmm.
Does fibroids automatically mean you can do an embryo transfer? My OBGYN, I'm going to continue, has said I will be fine, but this fertility doctor says they won't do it. For a fibroid that is not even inside the uterus in 4 centimeters. I have had 3 fibroid removals already. So she's asking, does fibroids automatically mean you can
I
do
think
an
she means
embryo transfer?
cannot. I think she means
Cannot
you
do.
cannot do.
Yeah,
Yeah.
right.
The answer is no. So I think it really, for me, fibroids are like real estate, right? Location, location,
Location,
location.
location.
So no, there are people with fibroids, as long as we can see the uterine cavity. If your other fibroids are making it hard to do ultrasounds to effectively know where your embryo should go, then that might be a reason to remove the fibroids, even if they're not sitting in the cavity. So I always put that caveat, which is just because it's not in the cavity doesn't mean that there aren't other factors it may impact. However, if it's not in the cavity, it's 4 centimeters, it's just the one. I definitely put babies into uteruses or uteri that have fibroids sitting outside of the cavity. But I think, certainly again, second opinion, right? I wouldn't ask the OB-GYN because ultimately as the way things are designed right now in the world, the OB-GYN who's a generalist is unlikely to be the one transferring your embryo. But what you need to do is seek another opinion, right? And again, ask the details. I know for many people, one, there's a fear of asking doctors questions, and there's a fear, particularly amongst people of color, that if I ask a doctor one question, now they're going to think that I don't trust them and they're going to harm me. I want you to feel free to know that doctors can't just harm you, okay? You have protection. So that's the first thing I want you to know is you actually have rights. There's something called a Patient Bill of Rights, and you're entitled to ask follow-up questions. So one is to say, hi, doc, I understand you're saying that I cannot have a transfer because of the fibroids. Can you explain to me how things, what it is that you're predicting and why, right? Have they actually looked in your cavity? Did they take a camera, a hysteroscopy, which is the gold standard assessment for the cavity, and look in? Because some people, they have a fibroid that's not in the cavity, but it's pushing down on the cavity, right? So it's actually causing what we call mass effect on the place where the embryo is growing. Now, I'll be honest, we do not have any guidelines from any professional society that says mass effect automatically means you cannot have a transfer. But I could see some private practice physicians deciding that they're not going to for that reason. And so it's really, really important to ask what is their rationale. And if you disagree, seek a second opinion. I recommend second opinions all the time, even to my own patients. I offer it. It's not because I don't think I'm competent. I know I'm competent. I know I think full picture for them. But I also know there are a number of things. One, if a patient doesn't feel safe or feel like we have that balance, I don't think anyone should be in a relationship where one of them doesn't trust the other one. I'll be honest, including medicine.
Life lesson.
It's a life lesson.
Honey, that's a life lesson
Yeah.
across the board. You said that there. I don't think anybody should be in a relationship with somebody where they both don't trust each other well.
Yes, absolutely. And so the same goes for medicine, right?
Yeah,
and
it
so
does.
If my sense is that the patient doesn't trust my judgment, if my sense is the patient says one thing here, but the other thing when we're done talking with other people, then maybe I should help you find the person that would give you that confidence and that trust and that safety, right? It's not that I'm unsafe. It's not that I can't hack it. It's that I don't think this relation is the best for you or me. Right?
I love that. And there's something also that you said that I just want to mention is that sometimes that private practice doesn't feel comfortable doing something. And I think it's really key to know, because we've talked about fibroids on Warrior Wednesdays several times, and all of the different ways to treat fibroids. And one of the things that stood out that you said to me once is sometimes a doctor won't suggest something because they're not comfortable with that technique. So it's not
Correct.
always, and I would rather them not suggest something that they're not comfortable doing. Don't
Yes.
do it on me if you're not comfortable doing it.
Correct.
So there's
Correct.
many reasons why we
Mm-hmm.
might get these
Mm-hmm.
answers. And I think that's why you saying,
Mm-hmm.
what is your rationale?
Correct.
To that decision, so that we can better understand
Mm-hmm.
it. Let's just do one or two more. I love all the doctors
Absolutely.
in the room, by the way, because I want to make sure you have your break before.
I'm good. I'm good.
Oh
Listen,
my
I slept
gosh.
after we talked this morning on Twitter Spaces. I went back to bed. I had breakfast and went back to bed. Don't worry.
Listen, we were talking about mental health. I went to the gym, girl. I was like, let me get my endorphins going for Dr. Duke today. I love that. Okay, so we have some questions here. Let's see. Somebody wants to know. Fibroids are in the building today. If I had fibroids as big as 13 centimeters,
that's big,
and do want to have babies, what treatment would you recommend? And again, I think that's also location.
Listen, Kelly can do these now. It's location. It really is. Now, 13 centimeters, admittedly, is big, right? And so even if it's not sitting anywhere near the uterine cavity, I would be concerned that if it's 13 centimeters and you're not pregnant yet, what size will it get to while you're pregnant? Because fibroids grow when people are pregnant. And one of the things that happen is they can also outgrow their blood supply. And one of the most painful things to watch is someone whose fibroid outgrows its blood supply during pregnancy and it starts basically dying, or what we call necrosing. That person ends up with a chronic pain syndrome during pregnancy. That is awful, right? I've literally had patients like that admitted to the hospital with just painful period. Depending on the location of the fibroid, maybe it's not sitting in the cavity, but it might get in the way of a delivery as it grows and so forth. So it's location, and taking the constellation of symptoms into consideration. So where is it located? Not just in the cavity, but let's say it's sitting right under the bladder. Well, that's right where we need to cut into if we had to do a C-section, an emergency C-section. So maybe we talk about removing it before you get pregnant, so we decrease the complications that can happen for a C-section, right? Maybe it's sitting so high up that your uterus is going to look much bigger faster during pregnancy, but also, like I said, it outgrows its blood supply and you end up in pain. So we talk about it. Ultimately, it's up to the patient to decide if they should have surgery. I think there's a misconception out there that the majority of doctors who propose surgery is because they want to make money. I'll tell you guys, we don't make a lot of money from fibroid surgery. We don't, right? I really want to disabuse people from that thought, because I know there are people out there. I was actually in a room with a very highly regarded music executive who, part of what he was sharing with people was that doctors just propose procedures so they can make money on you. And certainly a lot of the things he was suggesting he'd heard were not things that I know to be true standard of care and practice. But this is how you can test if someone's proposing standard of care to you. And I use that word because I see my friend Dr. Lloyd Brown, who's a transplant surgeon, also mention it up there.
Hey, doctor.
Second opinion is a way for you to verify, am I being offered standard of care? Now, second opinion isn't just so you can keep going until you find a doctor who tells you what you want to hear. Right? Now, part of it might be that reason you want to hear a certain thing, but also make sure they're proposing standard of care. How do you know standard of care? Standard of care means that after you've talked to me, you can go on the American College of OBGYN, the American Society of Reproductive Medicine sites, our professional societies, the societies that govern us, and you'd see the standard of care listed there, right? That's the first thing. I think one of the interesting things, and we see it playing out right now with the pandemic, we have evidence-based data that shows vaccines work. We even tell you what the efficacy is. And there are people out there who'd prefer to go take ivermectin that has no evidence, no standard of care. They're shooting things up into their nose like betadine and hydrogen peroxide nebulizer. Why? And there's no evidence, because that's what they want to hear. They really want to believe that stuff works. And so I do caution people as well, because again, I'm a huge advocate for making sure that we within medicine do right by you and that we give you the complete picture. But I also want to charge you, the patient, to make sure that you're seeking out standards of care that you know how to assess when you're being offered standard of care and when you're being offered thorough pictures. And that's why I'm always shocked, like I shared with Calais here, when I hear people who say, you know, yeah, I had a fibroid embolization at 27. I say, did they ask you about your future fertility? No, it didn't come up. Did you mention it? No. And it's because I know, unfortunately, there are people out there who, for some reason, especially when they talk to women, and when they talk to women of color, we put those intersections in there and we end up with half the story, which leaves us also feeling like we were not cared for well. And that's the problem.
It really is. And this is, I mean, these are the things I always think about Mama Stu. You guys know that she's a frequent flyer also at Warrior Wednesdays and help me
Hi,
freeze
Mama
my
Stu.
eggs. I know I saw all those comments. She said, Dr. Duke is brilliant. She loves Dr. Duke. I mean, that's her girl. And Dr. Duke's mama has been to Warriors as well. And so they hung out in the comment section. But, you know, that's one of the things that I just want to commend you. I just want to give you your flowers. If you guys could just put a whole lot of flowers in the comment section right now to Dr. Cindy M. Duke, the birthday girl, because you take time outside of your practice to talk to us on every social media platform to debunk the myths, to talk about health. I see my sister Niecy Nash is in the building. Hey, Miss Niecy Nash. That's why I couldn't answer your phone call, my love. I was talking to Dr. Cindy M. Duke. Put flowers in the comment section, y'all, because Dr. Duke has been doing these talks, not just with me, but she's on Clubhouse, like she said, with the Dynamic Uterus. She is on Twitter talking in that space. She is on FaceTime. She is on Facebook. She is on IG. She has the website.
I promise y'all, I sleep. It's all scheduled.
How you do, because you also have a directory. I hope you see those flowers coming your way, girl.
I do. Thank you, everybody.
I hope you see them. You also have a directory of Black doctors. And I think that it's really important for people of color, because we do know that there are internal biases, right? And we're not saying that everybody is that way. We are not, you know, pointing fingers or shaming. Yes, for the gorgeous flowers, y'all. I love you, warriors. We are not shaming it, but we do know that there are internal biases in our healthcare system, and we do need to address it. And so it's really lovely to have a whole catalog of Black doctors, of people that look like you, that you might feel more comfortable asking certain questions to. So Dr. Duke has that on her website. And before we let you go, we're gonna go through all the platforms where everybody can follow you. But I just want to ask one or two more questions, because
I have time. Go for it.
So patient. Okay, let me see here. Wait a minute. I'm a patient who doesn't have fallopian tubes. And I have PCOS. Is that still normal to have irregular periods? And does that play a role in having PCOS?
So not having fallopian tubes, I'm going to presume that they were removed surgically for one reason or another. But yeah, so PCOS and a lot of the symptoms that you see related to absence of periods is driven by that conversation or absence of complete conversation between the brain and the ovaries. And so it's really important to know whether you have fallopian tubes or not, the conversation is happening. And that's the thing about hormones, right? Hormones travel in our blood. So they don't need actual organs to travel through. Like, yes, if you look at a picture, it shows the fallopian tube as sitting between the uterus and the ovary. But that's not how the hormones are going to get to your uterus to help regulate periods and so forth. They get there via blood supply. And so, like I said, the big issue for those who have PCOS and don't have regular periods is that they're not ovulating on a regular basis, and hence the periods being spaced out. Now, some people with PCOS, they ovulate once a year, others a few times a year. What's hard is to predict which month that's going to happen in. And so that's why your periods are irregular. Like I said, if those periods are irregular, where they're spaced out, we want to ensure that we're protecting the lining of your womb. And so one of the things we see when we look at endometrial cancer statistics, now there are different cancers of the uterus. I'm speaking specifically to endometrial cancer. We notice that higher rates of endometrial cancer occur in patients who have a history of PCOS with irregular periods. It's especially higher amongst those with PCOS irregular periods who are African American, Hispanic, And it's especially higher amongst those who come from socioeconomic backgrounds who don't either have access to care or where the quality of care should be better. And so this is why part of this is taking it to you, right? Because your chance of uterine cancer is 4 times more elevated if you have PCOS and have irregular periods. It's important that you know that. It's even greater than 4 times if you're also a smoker, right? And so it's important to know your risk factors. It's important to know. I cannot tell you, and Dr. Sharon will tell you as well, we are OB-GYNs. Endometrial cancer is the most curable of all gynecologic cancers. It's not the most common gynecologic cancer, but it's the most curable if caught early. And so it's so heartbreaking to see so many Black women show up with advanced stage endometrial cancer. And you're probably wondering, Kelly, why is it so curable? It's curable because usually it presents with a history of either abnormal heavy uterine bleeding or irregular profiles. We happen to know that in someone even under age 40, we actually have guidelines. The American College of OB-GYN actually put out a special guideline that says if somebody has irregular periods, meaning anovulatory periods, and shows up with abnormal uterine bleeding, is, it could be frequent, it could be once every few months you have a heavy bleed, it could be once a year you have a heavy bleed. We should do a biopsy, a sample of the lining of your womb. And that's because they want to make sure we rule out this thing, which is endometrial cancer. Because again, we can catch it early. We can even catch it before it becomes endometrial cancer when it's called hyperplasia, and reverse it, but help you catch it, because it usually presents at some point. It's going to show us that it's there with irregular bleeding. But I cannot tell you how many people I meet in my own practice, but also who we meet in my Dynamic Uterus Club, where they either come in the PCOS room or they come into the period room and they're talking about irregular periods, and we ask them, have you had a biopsy yet? And they said no. Or they say, I told the doctor I don't want it. And it tells me, one, it may not have been well explained to them why. I know also there are people out there who think doctors just want to assign cancer to someone, but that's not why. We're actually doing the biopsy so we can help save you early, ideally, and give you that freedom that you need to continue in this planet. And so that's the thing that I want people to know. Similarly, if you have a family history of uterine cancer, colon cancer, and you're sitting here and you know this, make sure you tell your doctors about this so they can check to see if you have a genetic risk factor known as Lynch Syndrome for this. It's important that we talk about these things. It's important we talk about it in the family, right? So if they say auntie so-and-so, grandma so-and-so died from uterine cancer, find out more. How old was she, and do we know more about that? If you suddenly are thinking and the whole family is people with uterine cancer, colon cancer, breast cancer, prostate cancer, make sure you tell your doctor these things. And if they're not listening, you can also schedule yourself for a genetic counseling session with a genetic counselor who can build out for you a family tree. Now, this is not Ancestry.com. Ancestry.com, their job isn't to figure out medical risk, okay? So you need a genetic counselor for this. They're going to help you build out that family tree and help you figure out what testing you should probably get.
I'm floored. Everybody put blown mind emojis because I'm floored. I did not even know there was a genetic counselor that I could go to know these things, because you know what, Dr. Duke, and because it also is World Mental Health, something that you said, when you do find out that there's a history of something, uterine cancer, colon cancer, a lot of times our anxiety can't take getting knowledge about, do I have that? Is that something that'll come my way? And so we'll stay away from the doctor. We'll stay away from telling someone I have irregular bleeding going on. And that's the thing, is that sometimes we normalize things as a coping mechanism because we honestly don't want to know. We want to encourage you guys here. We want to encourage you. As she said, it is the most curable of the uterine cancers. We want to encourage you to know that there are wonderful doctors and there's a lot of great help out there, and don't remain ignorant because you're scared. We want to empower you with this information. That's
Mm-hmm.
why Dr. Duke takes the time out. That's why I take the time out. And all of these lovely doctors that are on here today that have come in this space to listen to their colleague and to show some more support. I see Dr. Sharon saying genetic testing for appropriate individuals are also available.
Yes.
And
So what she's talking about is your doctor, your clinician can actually order tests even before you see a genetic counselor. But I bring up genetic counselor if you're someone who feels like your clinician is dismissing you, they're not listening to you, maybe you're like, oh, they always feel rushed. Now, one of the big things I talk about when it comes to, I feel like my visits are always rushed, is letting people know, Kelly, as an advocacy step, that they're entitled to ask for a longer appointment when they schedule visits. And it's easy. And don't worry about, oh, my insurance, my copay. Your copay is the same whether we see you for 15 minutes, 30 minutes, 40 minutes. Now, I want to couch this all by saying clinicians, doctors, nurse practitioners, we're under tremendous amounts of pressure, particularly those in our primary care specialties, to see as many patients as possible in a day. Because like I told you, they're not really making much money from a visit. And so you have to know that oftentimes the visits are actually dictated via the HMO plan, the hospital setup, the clinic has designated. It's not that your doctor just doesn't like talking to you, but the way around that is when you call to schedule your appointment, say, I want a longer appointment. Can you double book me? So if this isn't an urgent appointment, because again, an urgent visit, an acute visit is to deal with the problem at hand. But let's say you want to come in, you just want to talk, you want to explore a few things, right? Ask the person who's scheduling, can you tell me how long is this appointment for? If they say you're being scheduled for a 15-minute appointment, a 20-minute appointment, you could say, I would like a longer one. Can we double that up, right? Can you double my appointment?
Great tip.
Maybe the doctor won't be able to see you next week because next week's schedule is built out, but they can offer you a longer one a little bit out. And then you write down your questions, you get yourself ready. Maybe you bring an advocate with you, somebody who can help remember you have questions as well. Because that's one of the other things, right? We get there and we're anxious, or maybe they throw a diagnosis at you, or they tell you a test result you were not expecting, and you forget. You forget everything else. So write it down. And then the other thing I say is, one of the things I have noticed in my training, but even as a doctor in practice, right? If someone says, Dr. Duke, it was really important to me that I get these questions answered. If I didn't get to that question, I would pause and answer that, or I'll say, okay, can you leave me the questions? I'll go through them and I'll get them to you. Dr. Lynette is saying, also come to your appointments on time. Absolutely.
Yes,
and
doll,
it's out
your
of
health.
courtesy. It's your health, and it's out of courtesy to the next person, right? Because if you show up late, now you're eating into the other person who scheduled their appointment, their time, and that is something that starts trickling into the rest of the day, and now everybody's off. Or your doctor doesn't eat lunch because they had to work straight through lunch to catch up so that they can keep going with the rest of the day. So it's important to keep your appointment, and don't call 3 minutes before you're due to say I'm running late.
Right.
We usually know you're running late long before that, right?
Exactly.
So that's important. But you can ask for a longer appointment.
Hold on, I don't know who that is. Okay, somebody was trying to get in. I don't know you though. I don't know you though. So I was today years old when I found out that you could double up and ask for a longer appointment. I don't know who else was today years old, but I'm not ashamed to say that it was me. So Dr. Duke, I am going to graciously, Dr. Duke will be back. I hope, I know. This is my way of asking in the future.
Always.
You guys can see how amazing this woman is and how much information she gives and how well we can absorb this information. I mean, it is just first class knowledge here. And there was a lot of people here that said, can I get an appointment with Dr. Duke? So Dr. Duke, what I want you to do, if you can, is tell everyone how they can get in contact with you, all of your social media handles, everywhere you're going to be speaking. You have announcements coming up, and y'all can always check. And you can always check my stories, honey, because when Dr. Duke is speaking somewhere or doing something, I'm going to repost the story because I'm going to send everybody her way. People are saying, thank you, Dr. Duke. Throw some more flowers up and tell them where they can find you.
Yeah. So I just shared our website, which is, you can actually request a an appointment with me online at fertilitynevada.com/contact. That's one way. The other is you can text us. We do have two-way texting, and on the next full business day, someone will get back to you about an appointment. I point that out because yes, we do reply to people after hours, but we reply to current patients after hours. But if you're going to be a new patient or you're not yet our patient, then we'll get the information and we respond to you on the first business day. And so you can also text us at 702-936. I'm typing it in as I speak.
I see.
8710, and they'll get to you that way. Across social media, I'm Dr. Cindy M. Duke, so DRCINDY, M as in Mary, Duke, all one word. And so you can find me here on Instagram. I'm currently fighting with Instagram because I'm pretty sure they shadow banned me, I can tell. Ooh. But that's a separate fight between me and them. And I think it has to do with this silly COVID thing going on, which is if the algorithms see you posting a lot about COVID, then it, does all sorts of things to your algorithm. But anyway, that's a separate fight. But I'm on Twitter, I'm on Instagram, Pinterest, LinkedIn, Facebook. I'm also on Clubhouse, all the same handle. On Clubhouse, we have the largest reproductive health, pregnancy, and fertility focus club on Clubhouse, or one of the top 10 health clubs.
I love it.
Yes, we've been named amongst the top 10 health clubs on Clubhouse by Parade. And you can go to My Dynamic Uterus to find a full schedule there this month, Kelly. So like I said, we do PCOS talks every Wednesday. Mm-hmm. It's at 7 a.m. Pacific. I apologize to you West Coast folks who are like, that's too early, but I'm a surgeon. It's better I get things done early in the morning.
You heard her.
So
She's
a
surgeon, honey. She got to get it done. Yes.
I got to get it done. So I wake up early, I do things early, and I move on with my day. But every Wednesday at 7 a.m., we talk about PCOS, 7 a.m. Pacific. But I also like 7 a.m., guys, because it allows people in other time zones around the world to make it as well. And we do 7 a.m. every Saturday. We talk about periods. And I love seeing that there are people here who I imagine identify as cisgender male. I encourage you to come to these meetings. It's not just for people with uteruses and people with ovaries. It's for everyone. It's how we empower. It's how we advocate. It's how we ensure that everyone is given safe, accurate, evidence-based information and not fear-based marketing. We're not selling anything, we're talking health. And then more, Kelly, this month. So next Saturday, we're going to talk all about how our skincare products and things we put into our bodies can impact our hormones, including our fertility. Many people don't know that. So we're going to talk about that. And we're also going to do a room, prepare yourself, guys, about the importance of orgasms and how they prime sleep.
Is Niecy Nash, is my sister Niecy Nash still on here? I gotta send that to her. That's going to be on your Clubhouse?
On Clubhouse. We're doing it on Clubhouse. We're gonna have sleep specialists. So this is no hokey pokey conversation.
What
We're
date
literally
is that,
gonna talk
Dr.
the
Duke?
science. So it's 2 Saturdays it's the 3rd Saturday of the month. And it's going to be a good conversation. I'll share with you once we start promoting it.
Yes.
But it's a great opportunity to come hear the science of it, come hear how it works, what hormones are involved, because there are hormones involved in all this. And I think it's important that people hear this information and understand the science of it.
Like I said, if my sister, if she left, I'm going to make sure that she's there that day because I cannot wait for that conversation. Yes. As you guys can see, Dr. Duke is all the things. She is all the things. Uh-oh, did I lose you? Hold on, it's buffering. Can you guys hear me? It's buffering. It paused. Hold on. Can you guys give me a thumbs up if you hear me? She's back. Okay, hold on. She's coming back because I want to be able to save this whole thing so I can say a proper farewell to my friend. Hold on. Let's see.
I see you.
Okay, there you are. Okay, I want to be able to say a proper farewell. Like I said, you are saying all the things. I can't wait for that orgasm talk, girl.
Yes, I think it's a good one. It's going to be a good one.
It's a great one, Dr. Duke, as usual, but especially you spent almost 2 hours just just pouring into us, bringing all of your doctor friends here into this room. I just want to thank you so very much for this informative and amazing live. This was long overdue, and you spent so much of your time, you guys. Please follow Dr. Cindy M. Duke, Dr. Cindy M. Duke, across all social media platforms. Support her, tell a friend about her, tell your family members about her, and she is out here for you. We're out here for you. So Dr. Duke, until the next time that you join us on a Warrior Wednesdays, whatever day you can, Miss Surgeon, whatever day, until then, happy birthday to you. May God continue to bless you and your family, and we honor, we salute you. So thank you so much for being here.
Thank you, everybody.
Mwah. I love you, friend. I love you, friend.
Yes. And for those who are on Clubhouse, join us at 3 p.m. Pacific, so 6 Eastern. Clubhouse partnered with Nidhi Terari, who is a mental health specialist, to do 24 hours of mental health promotion. And the title is Mental Health in an Unequal World. And the whole format is every 90 minutes, a different country or different region in the world discusses what mental health means in their part of the world and what are the inequities that prevent equitable distribution of mental health care. And so I'm doing the Caribbean region. Dr. Sharon Smith, who's here, who's from Antigua by birth, she'd be there. Dr. Leslie Ann Williams, who's also from Trinidad and Tobago, she'll be there. And we've invited a few guys as well to sort of balance out some of the genders, because we don't have a full representation of the gender scope that is in the Caribbean. But it should be a good talk starting at 3 p.m. Pacific, 6 Eastern, 90 minutes. Come through. If you're from the Caribbean, we welcome you to the stage as well to come share your experience about mental health, mental wellness, and the inequities that you may have experienced either personally or seen family members or your community experience. So thank you so much, Kelly. Of course, I think you're such a champion for the cause. And this is why I always come back. I was actually reviewing one of our videos from this same time last year when we were talking about viruses and pregnancy and why vaccines would make sense and how vaccines work, including flu shots. And so before I leave, I want to remind people again that it's time for getting the flu shot. Flu before boo, boo being Halloween. So now's a good time to get your flu shot, guys. Go on out. It's safe. If you're planning pregnancy, flu shots are safe. There are even flu shots specific for those who are pregnant and those who are under 6 years old. So get your flu shot in addition to the COVID vaccine.
And I love that. It's amazing that it was a year and I was sitting in this exact space. I was visiting home, except I quarantined in the sunroom for almost 10 days before I came in here to do this live. And I'm happy to report, because at that time, I think Mama was waiting on a vaccine, maybe, I don't know. But she got her booster and she got her flu shot. Both of Mama's still in Papa Bear. Y'all haven't met Papa Bear, but that's my daddy. And he got his flu shot as well. So a year, we're going to have an anniversary party then.
I think we do.
I feel something coming around. So I hope you saw all the flowers and all the happy birthdays.
I did. Thank you, everybody.
I love it. I can't wait to listen to Clubhouse today on 6 p.m. Eastern.
Correct.
That's 3 p.m. Pacific, you guys. I will be listening in on that talk. Dr. Duke, thank you. I adore you. To the moon and back. I love you back, friend. See you on the next one.
See you next time. Bye, everybody.
Bye-bye. Thank you so much. All right, y'all. There she is. That's Dr. Cindy M. Duke. I love her. Like, I love her hard. And she knows that you will always have a friend, always have a supporter, always have a champion in me, Dr. Duke. Thank you so much for that invaluable time. I hope you guys know how much information you were just given and how much power you were just given to take control of your own health, your own wellness, mental health included, y'all. We are here to always support you. I'm going to post this. Please share it with a friend or a family member, a neighbor, or even somebody that you don't know. There's so much valuable information that will hopefully encourage you and change your life for the better. Thank you so much for joining me on this Sunday. Thank you again to the incomparable Dr. Cindy M. Duke. Mwah. I will see you soon. Bye, everybody. And thank you, everybody in the comment section. Y'all rock it. The squad showed up. I see you, warriors. Mwah. I love you.